Uh, Assalamu alaikum. Today we will continue the topic of thyroidectomy. The majority part of pre-operative preparation and planning, anticipation we had already discussed. So today it will be a slightly quicker class, and we will be discussing the problems which someone face while anesthetizing a patient for thyroidectomy, or a thyroid patient with thyroid disease or goiter for non-thyroid surgery. So we will just try to cover both aspects. So when you have a patient planned for thyroidectomy, is there any difference in different types or anything which will be included in addition to thyroidectomy sometimes? Sumaira, do you understand my question? I will repeat that. Is there anything which may be done along with thyroidectomy? Anyone, please?
So I didn't understand the question.
Like actually, there sometimes they are also doing the neck dissection along with. Can all of you mute your mic? This is very distracting. Yes. Dr. Qasim, please kindly mute your mic. You are, anyways. Okay, so sometimes thyroidectomy is combined with neck dissection. Okay, so in that, so that that may be part of it. So you have, or sometimes they are doing subtotal or total. Okay, so you should be, not your concern. Majority of times will be the same. Okay, but just you should be knowing about it. So so what will be the challenges in patient undergoing thyroidectomy? First thing will be airway. The metabolic problem, whether it is hyper or hypo. What else? Please come on. What are the other problems which we should be considering? Is there any risk of air embolism? Is there any problem related to endotracheal disconnection? They are near major vessels, so bleeding can occur. What else?
Why is air embolism a problem here?
Air embolism can occur or no? They are doing it.
I didn't get it. How will it occur?
No. When they are doing a surgery, they are making the head side up. So any surgery which is occurring above the level of heart, there can be air embolism. Got it? Anything else? Concerns related to vocal cord. Okay. Vocal cord problems. Then tracheomalacia related, post-operative, and then later on, because parathyroid will be removed. So concerns related to parathyroid and hypocalcemia. Okay. And post-op airway obstruction. Okay. And acute crisis in the form of either thyroid crisis or mixed edema coma. Okay. So this is just a summary of the problem. So if we just focus on airway, so if you have a patient with the enlarged thyroid, so what should be the safe choice of managing the airway?
Sir, if it is a large goiter, then we can go with the awake fiber optic intubation.
Okay, what else? Other than that,
And
what
then
will
we
be the
can
safer
go with
option?
the spontaneous within inhalation induction with spontaneous ventilation.
Okay, what else? With check laryngoscopy. Okay, so what can be the
Yes,
problems?
exactly.
Because awake fiber optic, you need to counsel the patient, you need to have the airway anesthesia. Okay, so these are the problems. So this is related to awake fiber optic, and you should be calculating the dose of local anesthetic. Okay, because here you can we use up to 9 milligram per kg of lidocaine. Okay, so we have discussed before about this 10% and 4% spray. Okay, and usually 1 ml is equal to 10 puffs usually. Okay, so if they are giving 10% means 100 milligram per ml, and 4% means 40 milligram per ml. So similarly, you can calculate the safe dose. So this is one challenge. Of course, counseling and assessing the airway, sorry, what individual nerve blocks or spray as you go with gargles, nebulization, nasal plagets. Okay, so these are the things which is so other when you are doing it, for example, spontaneous ventilation, elimination, induction, still some problems can occur. What are those problems? Airway may collapse. Okay, so have you heard of reverse Salic maneuver? I have discussed multiple.
Yes, sir.
What is that one?
Yes, sir. In case of large spider, when we do for say mask ventilation and if airway collapse and we are unable to ventilate the patient, and our assistant he tries to move the wider upward.
Yes, just like Salic maneuver is pressing in the area of cricoid cartilage, it is lifting the thyroid swelling to remove the obstruction. Okay, so this is one thing you can do. Or for example, if there is another option is to do lateral. Okay, and for example, if it is obstruction like tracheomalacia, so the third option will be rigid bronchoscope. Okay, so like these things should be in hand, because usually in this scenario, usually when we say that there is a Kiko, cannot intubate, cannot ventilate, so they are saying cricothyrotomy. Okay, or tracheostomy. Okay, so now can you do tracheostomy or cricothyrotomy in this patient? Unfortunately,
Very difficult.
it is very difficult, or
Sir, it will be a difficult task due to
practically
this
it will be
shortage
so.
in our
You will lose the patient if you are not able to handle the situation. Patient will have direct flight. So that's why you should be knowing about the possibilities which you should have in case there is airway obstruction. So one is you should not anesthetize, you should not give anything, awake fiber optic, spontaneous ventilation, if the airway collapse, reverse Salic maneuver, and lateral position and rigid bronchoscope. So these are the rescue maneuvers which you can have. Okay, because even if the airways collapse, even if you are trying to put LMA, even LMA will not work. Okay, so this is very challenging situation. So at least theoretically, if not practically. Okay, so this is something important about this one. Then similarly, like if you have documented vocal cord injury, you should be practically anticipating any problem post-operatively, so you will be going to HDU or ICU. Okay, so the other problem which you can have during thyroid surgery is thyroid crisis. Okay, so how will you pick it? What will happen in thyroid crisis? Tachycardia,
Tachycardia, hypertension, or marked hypotension,
okay, and
and
tidal CO2 will raise.
hyperthermia, and tidal CO2
Hyperthermia.
raises.
Okay, what else? Arrhythmias can occur. Okay, so like you are expecting it, and then you will be anticipating. So what will you do? What will be the steps to follow? Call for help, immediate
So first
info.
is call for help, then inform the surgeon,
Hmm.
and then ensure or and maintain the airway, breathing and circulation, give 100% oxygen,
Hmm.
and then we will give the paracetamol to control the temperature, and we will pass the
First
NG tube
is
and
saline. First of
NG.
all is IV fluids, then
Okay, IV fluid.
paracetamol.
NG plus Foley's. Okay, if it is not there, and you will do the cold saline irrigation. Okay. Then will you give this one aspirin to decrease the temperature?
no, sir, we will not give aspirin.
It will
Aspirin
increase
is contraindicated.
free T3. Okay. It will displace the binding, because aspirin is highly protein bound. Okay. So what else? Then now you will be putting through NG tube. You will also start this carbimazole or propyl thiouracil. Will it affect immediately?
First, Russell is given.
Will it affect immediately? Beta blocker.
So it's given through NG route. I don't think very immediately, but the other drugs are given after the propyl thiouracil. Also, potassium iodide and all those.
Yes. So for conversion, stopping the peripheral conversion, you will steroid. You will give beta blockers, not only to control the situation, but also to convert to inhibit the peripheral conversion. And this Lugal's iodine is then rest of the man.
We missed the propranolol. It's given in 1 milligram increments with
Yes,
monitoring.
beta blocker I have written.
And yes, sir, beta blocker. And then
Okay.
hydrocortisone also.
Hydrocortisone I have written. Okay. So this one, and then rest of the management will be according to the situation, because any complication can occur, any arrhythmia can occur, rhabdomyolysis can occur. Like there can be similar, some of the things can be similar to malignant hyperthermia. Okay. So that's why when you have told everything, the last thing which you can mention is also dantrolene. Okay. Dantrolene has some effect to control the hypermetabolic okay. So this is how you will manage. So similarly, mixed edema coma, I have never, of course, I have not used, fortunately, alhamdulillah, I've never seen it. But similarly, this mixed edema coma, again, it will not be as acute, maybe as thyroid crisis. Okay, so this may be slightly subacute, and patient may have delayed recovery, for example, or patient may have like um, I think mainly this will be presenting as delayed recovery, bradycardia, hypotension, shock, like so hemodynamic collapse can occur. Okay, so what you will be doing? There is the IV thyroxine. Anyone knows about the dose? I don't know the dose, about how much dose it needs to be given. Lugal's iodine effective during crisis? No, but we will give to decrease the vascularity and as a follow-up management. Okay. So what else? So these are this just basic problems which you will be. Otherwise, as I told you, that the majority of the things will be just like any other surgery. And what will be the effect of MAC on MAC? So MAC will be unaffected. Okay. Other medications almost like if you are using cesatricurium or atracurium. So if in hyperthyroidism, maybe their metabolism is become faster, and you might need to give more dose. requirement. Okay. Similarly, there is an important question which they ask again and again: how to manage post-op respiratory insufficiency. Okay, because this is a commonly asked question, that you have a patient in post-op recovery following thyroidectomy. The patient is you are being called to see that patient is having respiratory insufficiency. So what will you do? What should be your answer?
So there are many causes for it.
Mhm.
Top of the list would be hemorrhage,
Hemorrhage.
then tracheomalacia,
Okay.
hypocalcemia.
Hypocalcemia will not be said that quick. Okay. This will be after 24 to
The
48.
late.
Okay. What else? You are missing. Will you think hemorrhage as the first cause? Residual
I
anesthesia.
will.
Residual
Yes,
anesthesia.
yes.
Okay. So there may be hypoventilation. I'm sorry. Vocal cord injury. Yes.
Vocal cord paralysis
Yes.
or
It can.
injury.
Yes. What else? So what will you do? Yes, Sumera.
Edema, sir. Laryngeal edema.
Laryngeal edema. Yes. Sumera, what will you do? What will be your course of action?
Sir, first we will try to maintain the airway, breathing, and circulation. And if we suspect that it is a hematoma, then we will try to remove the clips of the our sutures, and we will
You will
try
do
to
it?
shift.
Sumera, will you do it yourself?
Sir, we can call for assistance.
Call surgical team. Your approach will be
Yes, sir.
airway, breathing, circulation. You will do prop up. You will try to see what is the situation. You will give 100% oxygen with the bag mask. This one, sorry, reservoir bag. Okay, and then immediately you will call the surgical team if you are suspecting hematoma. Okay, and if they are not reaching, of course you can do it, but you don't say that I will open the clips. This is not your job.
Okay.
Okay, because you can create even more problem. Then so first of all, tell the things which are, maybe you need to reverse. For example, if hypoventilation is caused, so might you need to give this reversal agent or naloxone, okay, or flumazenil. Okay, so like try to tell the things which are related to you. So you inadequate muscle relaxation, muscle reversal, or opioid overdose, or benzodiazepine overdose. So say these things first. Okay, you might need to like help. You might need to secure the airway. Okay, by putting airway, or like non-invasively, you might need to do bag mask. So gradually you will tell the other things. Okay. Just a second. So anything else? This is the question which is yes, Zishan. Anything else you want to add?
For FCPS candidates, the thyroid production, thyroid hormone
We have done
production.
yesterday, day before yesterday. The first part we have already done. This one I forgot to tell, that you might need to have armor to this reinforced tube, which is kink resistant. Okay. And positioning will be a problem. The tube can disconnect. They do the head extension. They do the reverse Trendelenburg. Okay, and at the end, they might need to do the check laryngoscopy to see the documentation of this vocal cords. Okay. Yes, Nadir.
Maybe we'll evaluate any other drug anaphylactic reaction.
Yes, there may be angioedema because of some anaphylactic because of some anaphylaxis. Okay. So Sumera, anything you want to add?
Sir, one question, please.
Yes.
If we can see there is a hematoma on surgical side and breathing is not very well, we involve the ENT team, but
Yes.
they are little bit late.
Hmm.
Sir, we can reach out or not for airway breathing.
No, of course we can do it, but I'm just telling you that try to be like, because if you, this sentence why Sumera said, because it is written in the book that you will open the clips, but if especially if you are talking in Viva, you have to correlate the things. Okay, because it's not wrong. Of course you will say that you will immediately call the surgical team, but if you are seeing that it is expanding hematoma, so you need to open the clips to relieve the obstruction. Okay, so then it will be a more logical answer than just saying that I will open the wound. Okay, so okay, so I think we have covered major aspects of the topic. Okay, this laryngeal edema, as Dr. Humera mentioned, tracheomalacia, hypocalcemia usually occur after 24 to 36 hours. Okay, pneumothorax, especially, yes, you see this one I missed. Pneumothorax, especially if it is retrosternal. Okay, so I will highly suggest you people to read this. This is one of the book which is very easy to gather. It's very nice book. Okay, so it is case oriented, and because people will say that I am not preparing for Viva, so why should I read it? Believe me, in one case you will learn so much. If you just try to explore each and every word a little bit detail, you will find one X-ray, one ECG. Okay, so you will learn a lot. Believe me, this learning way, and then you can expand your knowledge by reading some details of the topics which are coming. Okay, so thank you very much. Any question, Sumera? Is it okay?
Yes, sir.
Okay, so before I finish, I will just answer the question which I sent in the group related to just discussion topic, that there is a patient with morbid obesity for liposuction and abdominoplasty. So actually, in addition to all the problems related to like any anesthetizing any patient with morbid obesity, the extra thing here will be that in liposuction, there can be incidence of fat embolism. Okay, this is one thing. They are putting a lot of local in their solution which they are putting inside. So sometimes it can cause, so you have to be very careful about how much they are putting it. And then they also add some epinephrine, so that may also absorb and can cause some problems. So this is one of the extra point. Then in abdominoplasty, actually when they are trying to close the abdomen, sometimes the abdomen becomes very tight and it can create problem related to your breathing. This is one thing. And even so, after finishing of the procedure, they put a belt which also cause problem post-operatively, especially in a patient with the which is already have some respiratory compromise. So rest of the things is like any other surgery, like all the assessment, you will be evaluating the patient clinically, and then you will be seeing any risk factors for OSA If there are risk factors according to stop bank, then you will refer for sleep studies, and then you will see the individual system. Is there any problem in the cardiovascular system or respiratory system, and you will act accordingly. Okay, so the only important only point which was extra I have told you. Okay, because sometimes they are doing it as a combination. They will do some liposuction, and then they will do this abdominoplasty, which is called just tummy tuck. Okay, so this was just a feeler question which I asked in the group in the morning. So next, inshallah, we will do some other topic. I will, inshallah, most probably, if we over the weekend, if we can do cardiac patient. Okay, cardiac patient for with reference to long case, or we will just discuss how to evaluate patient for non-cardiac surgery and how to interpret the findings. Because Sumaira, that case, if you do in that way, it will cover all hypertension, ischemic heart disease, heart failure, valvular heart disease. Because the evaluation, I have done this topic a number of times before, but if you do a cardiac patient like that how will you evaluate the systems? How will you rule out the organ decompensation? And like how will you do the risk stratification? Okay. So thank you very much, all of you. Inshallah, we'll meet again.
Thank you, sir.
Okay. Salam.